Welcome everyone to today's webinar, How to Create an Effective Cost Reduction Strategy and Achieve Non-Labor Cost Savings in the Age of COVID-19. I am Brian Zimmerman with Becker's Hospital Review. We'll begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, I'm pleased to introduce our presenters for today's webinar. Lisa Miller is a healthcare margin improvement expert and the founder and chief executive officer of Vi Healthcare Consulting. Lisa Miller is a recognized leader in healthcare costs, hospital purchase services, healthcare benchmarking, supply chain management, and performance improvement. Since founding Vi Healthcare Consulting in 1999, she and her team have generated over $700 million in cost savings and revenue improvements for their healthcare clients. Lisa's approach is comprehensive and enterprise-wide. Richard Dormer is a healthcare margin improvement expert and the chief operating officer at Vi Healthcare Consulting. With extensive knowledge of hospital expenses across the organization, Rich identifies and achieves dramatic cost reductions for the clients of Vi Healthcare Consulting. His subspecialty is hospital purchase services and physician preference items. And at this time, I'm pleased to turn the floor over to Lisa to begin today's presentation. Take it away, Lisa.
Great, thank you, and welcome everyone. We have a jam-packed schedule for this hour, hoping to get a couple minutes at the end for some questions. So we're going to go through some of these slides quickly, but we have a lot to present today, so welcome. As everyone knows now, this is myself and Rich from Vi Healthcare, and welcome. The only thing we ask, this presentation is copyright protected. The material can't be used, shared, or screenshot without Vi's permission. However, if you are an employee of a hospital or health system, please email me. I will absolutely send you this presentation because this presentation is really meant as a workbook. So there's a lot of value, a lot of details in this, and we're going to cover some a little more quickly. So please, if you're an employee of a hospital or health system, email me. I will absolutely send this to you. So on today's agenda, everyone has seen the outline of what we're going to cover. Those are the items. In addition, we have a cost opportunity scoring and framework. We have a specific COVID cost impact examples we want to show, some strategies, and then a special offer for hospitals. If you stay at the end, we've got a couple of offers for you. So here we go. A little bit about Vi Healthcare. We've been working since 1999, so it'll be 21 years in August, to help hospitals reduce their non-labor costs. And that is our focus day in and day out. So in all areas, in all capacities, our focus is non-labor costs, and we support health systems to achieve their goals. So just a little bit about us, and we're going to jump in. There is an unprecedented pressure to find cost savings opportunities. I don't have to tell anybody on this webinar that there are external dynamics that are forcing hospitals to track nearly every dollar spent. The efforts around pricing, utilization, and building internal supply chain sourcing, and also department cost savings expertise is absolutely critical, and we're going to talk about that today. So having a proven cost strategy is mission critical. So as we're seeing in the marketplace and working with our clients and talking to hospitals every day, everyone's journey is similar. Everyone is coming out of COVID-19, and that financial recovery needs an approach that has structure, rigor, and discipline. So we need to have a cost saving strategy. Got to have a culture of cost awareness and continuous improvement. Got to remove those spend silos and those sensitive areas of spend. And everyone on the call, knows those areas that haven't been looked at for one reason or another. And we're having hospitals that are looking at those areas where they never really wanted to look at before because they have to. And I think one of the most important areas is building competencies internally and accountabilities that drive success. It's very important. We want to help recreate and rebuild. So I'm going to have a little bit of an activity. This is what we use when we are beginning our cost-saving strategy sessions. It's called a cost opportunity score. And you can do this yourself. We're only going to spend a minute on it, but it's just really meant to kind of get us all thinking and aligned. So you can calculate your score. It's 0 to 10. There's 6 categories, and just kind of do it, right at your desk. So 6 areas. Is my pricing right? The utilization right? Do we have systemized data analytics? Do we have a culture of cost awareness? Have we adopted cost innovation? And do we have a disciplined cost management? So let me go through those 6 areas. And this is meant to score. So have you got the pricing right? I know everyone speaks about, well, pricing does not really matter as much as utilization, and there's always this discussion. In fact, there's still a tremendous amount of pricing opportunities to get that pricing right. Have you benchmarked from 2 or 3 external resources? One could be your GPO, but you definitely need to have additional sources of benchmarking. A cross-section of benchmarking is absolutely critical to see, just to get a view from different sources so that you know you're getting at the right price. Review of all your agreements annually and in term for pricing opportunities. A lot of times, or whether it's consultants or hospitals say, look, I'm going to wait till those renewals come up before we look at it. And at VIA, we say, no way. You should be looking at your agreements in term every year as much as possible. And it's absolutely critical to get in that discipline and not do what what most do, which is wait till those terms are up to review. You've got to be looking at your agreements in year 3 if you have a 5-year agreement, in year 2, in year 1 if you have a 3-year agreement. Have you analyzed to reimbursement when possible? So there's a number of areas in clinical services where you can map your cost to your reimbursement. Do you have the utilization right? Do you have insights into variation, standardization, and conversions? Do you have a systemized data analytics? Do you systematize data analytics? Do you use multiple sources of data to simulate, analyze? Do you visualize data on a consistent basis? And is every hospital running on some kind of metrics? 4, do you have a culture of cost awareness, a program for employees to understand and see costs and talk about costs? Do you have a scorecard and feedback system for physicians and surgeons in real time so they can see what costs, for what they've used in supplies and implants? Have you adopted cost innovation? Looked at insourcing to outsourcing, outsourcing to insourcing, new technology to help with visibility of costs, and also risk share models with vendors. And finally, and I think very, very important, because really the best cost savings is to have a discipline of cost management. So you're capturing those cost savings, you're preventing some of that leakage or that missed opportunity. So do you have access to line item details? Do you dedicate time each month to review utilization? And do you perform quarterly financial and operational business reviews with your vendors, but based on your data and based on you running it? So this is how we begin our cost-saving strategy sessions, and we score, right? So this is an exercise for you and for us to just kind of to get ourselves going, but it's a nice way to benchmark where you are, your organization, and just give you some insights into where we see best practices are, and having this kind of full view of non-labor costs. Okay, so here we go. We're going to get into some interesting information for everyone. So I think probably everyone on the call, if you drive, you've received a check from your car insurance company, right? So I give you one example. Progressive gave $1 billion in rebates to auto insurance customers. And why is that? Because during the last several months, we've had less drivers on the road, less accidents, they've had less costs. So they have proactively said, you know what, we've had less costs, we're going to go ahead and give our customers back refunds for, for their insurance premiums. And I'm sure everyone has had that happen. I had that twice happen with my insurance carrier. And so we want to talk today, one of the areas we're going to talk about is the definition of a COVID cost impact. Terms in your agreement where, one, costs that continue to be charged even though services weren't performed, and 2, costs that have a volume guarantee structure in order to receive a rebate. Both of those scenarios are going to cost, there's a number of different issues that are going to have an impact because of COVID, but these are 2 that we're going to show you. We're going to give you a number of examples where you've got to really uncover to find out where are those costs that are going to be charged even though the services weren't performed, and where are those guarantees, the volume guarantees, now that you won't make those commitments where you don't get a rebate. And so this is a question you don't have to answer, but just to think about, did anyone on this webinar receive a credit or refund from our vendor in your hospital health system in consideration of the COVID impact? And Rich is going to lead us off on some great examples.
And under the clinical purchase service area, there's a few examples here listed. Perfusion services always have a minimum monthly case volume. Now, nitric oxide, typically you'd see monthly minimums, and then if there was no volumes, obviously you're paying for that. But on the other side of it is net hourly rates, where a lot of our clients that we've seen, a lot of people in the industry have gone to this net hourly rate based on historical volumes, but because of the treatment of COVID-19, this was one of the areas that really could be spiking, and you won't know for another month or 2. Diagnostic testing, so a lot of times in the lab and the clinical side, these are set on a volume, and if the volumes go down, then you could fall to a different tier, the pricing would go up. Other examples here for facilities and sports services, regulated medical waste, bundled waste streams. They're based on historical baseline, and then a lot of the times the contract doesn't allow for a reduction of the baseline, only increases. So this would be a big impact over the last few months. Cleaning services, environmental services, some services you could find or should have found a way to pause or cancel altogether. And then environmental services, there's some fees. The fees are bundled in with the management fees, the labor, and all the supplies, again, from an historical standpoint, not from actual utilization.
So we had a client that had a midday cleaning fee. We helped them identify that, and they were able to remove that fee and save them quite a bit of money. So that's actually a current real-world example on the cleaning services.
Right. And then some examples in finance, HIM, rev cycle area, which is one of our purchase service categories, but the transactional fees, eligibility verification, again, based on historical numbers, but with a decrease in activity, you're paying essentially for air. Call centers, now typically there's a variable rate in the call centers, but there's always a set fixed amount that needs to be the minimum. Again, based on the last few months, there's probably opportunity there to go back. And then the physician practice, EMR services, while the agreements are based on the percentage of what is collected, they all have these monthly minimum charges that you're probably paying for. Biomed service and maintenance contracts, you have the mobile MRIs where, in the agreement they're usually set to be there two or three times a week or how many times per month, and you're still paying for that even though there's probably no use. Maintenance rental agreements, again, you're paying for historical usage based on what the contract terms are, but if there's no activity or the things that should be maybe not a full service or maybe a parts and labor, whatever it is, the things that need to be talked about and discussed. The next examples here are under IT, telecom, and telehealth. Interpretation services always have a monthly minimum. Patient statements, now these are coming through. We have an example later we'll go through, but these are fixed fees that are coming through per month. Telestroke, again, some of the telestroke programs have some variable rates to it, but most are based on a bed size or historical interactions, and therefore it's going to be a fixed cost. And then some administration and HR category, we have anesthesiology agreements. Now, they're typically based on if it's an outsourced and what the available hourly minutes are for the OR. And then if you don't hit that threshold, there's minimum guarantees. So if that wasn't adjusted, you're probably seeing some reconciliation payments or invoices come through. The vendors that provide surveys are always based on these bundled survey fees regardless of the amount processed. So it's going to be, again, historical, it's going to be fixed, and these are going to come through. And then another, really from a physician agreements, some agreements have fixed subsidies. Understanding what those subsidies are, and then having those conversations about it, because again, if the volumes are down, you're still paying for those fixed amounts. And then lastly, on just PPIs and supplies, and really, if anyone's been negotiating with the CRM, drug-eluting stents, reconstructive orthopedics, spine as well, there's many of them, if not all of the competitive ones, have a rebate component. Now, if you have a rebate built into your reduction, and obviously you're not hitting specific expectations or parameters within the agreement, now you are paying higher on what that volume is. Disposables and equipment rental, a lot of they're tied into the cost, even reagent rental agreements as well, where you're paying for the disposables and the equipment together. So if one goes down, you're still going to be fixed on that. Yep. And then on distribution, that's something that obviously pharmacy, med-surg, depending on the cost minus, cost plus, but these rates are based on a monthly average of the total spend. So if that comes down, then hospitals are being at risk for their pricing to go up.
So we're going to give you an actual example, like an in-depth case example. And the reason why we're spending a good amount of time on this is you can imagine, your hospital having 4, 5, 6, 8, 9, 10, 20 of these agreements, what that impact is. And so what we're suggesting is, just like Progressive and just like a lot of other companies have really understood that they've had lower utilization, they've had lower costs. They've been willing to say, listen, yes, let's come together for a period of 3 months, 4 months. We're going to reestablish, we're going to provide a credit or a 1 month no charge. But these conversations have to occur. In order for them to initially occur, hospitals really have to understand and know where to look. We're going to talk about that in a moment. But I just wanted to pause for one moment, because we really, here we are in June, we probably have another month or two when those conversations will be still relevant, right? But you've got to know, okay, where do these kind of agreements sit in my organization? And really, you've got to have them. And, there's a lot of organizations, vendor companies that are doing it proactively, but the hospital cannot bear the full burden of these these cost structures, and there's got to be a partnership in place to be able to address that. So Rich is going to give you an in-depth case example.
Okay. And this is medical gases, and just wanted to provide a step-by-step on how to identify, put together cost analysis, and then steps for negotiations. Obviously, first is to identify all the medical gas providers, and it seems like a simple step, but a lot of times, there are multiple providers under this category, and you want to make sure you capture everything. You want to get the 12 months worth of invoices, in some cases 18 months, but 12 to 18 months worth of invoices, and then categorize the spend into the bulk, cylinder, and service charges. Very important. When we get to the historical review, now from a contract standpoint, you want to map the current agreement pricing to the current invoice pricing. Now, again, it sounds simple, but a lot of times what we see is that the pricing on the contract is lower than what the pricing on the invoice is over a number of years. You can never just benchmark from a contract. Now, the other point is that the vendors need to provide notification letters when they raise pricing. You want to make sure that you have those, because we've seen examples where they have not been sent through and you're able to go back and get credits for it. And then understanding the term notification. These are long notification periods. We typically see between 6 months and a year notification. So it's important to make sure you lock those down. And even if you're in a situation where there's a long expiration, you could still negotiate with them. So don't hold it just because there's 18 months left in the agreement. The fourth step is now to build your analysis, right? So you want to build the line item utilization, again, from 12 to 18 months worth of invoices. Now you're expanding to an analysis of the entire historical utilization. very important. So because you want to look at all the delivery schedules and the frequency and all the different fees that are coming through. And then you also, last and equally important, is understand what the cylinder, the tanks on hand versus the typical cylinder utilization. So this gives you an idea, some insights into if you have a lost cylinder problem, because if you do, you're liable to pay that back. So understanding that, as well as the price increases, the ancillary fees, very, very important. And then the final fifth step is renegotiations. You don't want to go any further than 5 years. You want to make sure that you're focused on those annual price increases, because they typically saw one just last week, came in with 5% increases second year, after the first year, which within 3 or 4 years put it right back to where the current price was. So you always want to make sure that you're looking and focusing on the annual price increases, and you never want to just let one of these auto-renew, because again, they're putting these CPI increases in every year. It's going to go higher, so you always want to be negotiating these. And obviously tying the lost cylinder is important, because again, that's a leverage point for them, the amount of money that you might owe them.
So I just wanted to give you I have a question, and just really for be thought provocative, but could you locate all of those agreements, those issues within the terms of your agreements with 1 hour? And you may think, well, that's really impractical, Lisa. How could you possibly ask us to do that within an hour? But the idea is, if you had that located in one place, those terms that were abstracted for accuracy, and have a process or even one document that has the terms, and this really sits out of necessarily a contract management system, but more about abstracting and summarizing and really prioritizing certain agreement terms. And these agreement terms that have minimums, that have rebates, that have a different structure to it, need to be placed and housed in one location. Because in order, again, to be able to identify these opportunities, so you can have the conversation, so you can get the refunds, the credits, the allowances because of COVID, that's fair. You need to be able to address that. You need to be able to identify it, and we have a short window of opportunity. And anyone who wants to have a further discussion about this, you could reach out to me. But we really wanted to have this group thinking about going back in and saying, wait a minute, I'm going to go back and I'm going to find those agreements, and we've just identified hundreds of thousands. Who knows? It could be a lot more, depending on the size of your organization, by uncovering these terms and renegotiating for a period, requesting some kind of financial relief, which again is been industry-wide, as I showed you with the example of Progressive. Okay, so we move on. We're not going to cover in depth all of these strategies, but we're going to cover some of them. But I wanted to be able to at least have a little bit of discussion, go through the work that we've done and hospitals are performing all across the country, and that are really giving success, right? High-performing cost-saving strategies. One, that's a zero-based budgeting approach, right? So it's deciding if the supply or service is needed. Sometimes it's even, I didn't even know I had it. And when we go through the zero-based budgeting processes, it does require time, and we were helping doing the heavy lifting, but I will tell you it's a very, very insightful process. It's a worthwhile process, and many times within the departments, going to those line item details, sometimes they don't even know that they're being charged for it, because they just don't have access to that level of visibility. So it's really important. Clinical operations improvement, utilization, right? So you're identifying optimization, standardization, change opportunities, and connecting to outcomes. Pricing, again, we've talked about that. Pricing still matters. It's going to always matter, and we want everyone here to go beyond norms and exceed norms. And we'll talk a little bit more later on about that too. Supply chain excellence. We're a big supporter of building internal supply chain teams. Supply chain teams, we all found out these last few months, are critical to have a strong internal team. And we say, let's build the teams, let's build the capabilities, let's let's create a strong center of excellence within supply chain, and not have any way, shape, or form, outsourced or overly reliant on outside organizations. Yes, having resources, getting benchmarking, accelerating, providing analytics as a support, but always for the purpose of building an internal team. Cost awareness, we're going to talk about in a moment. We have physician cost awareness is very important. Cost improvement through innovation, data accuracy, so looking at your data from an item master, charge master, in the OR, surgical information systems, being able to make sure that underlying data is accurate. Spend analytics, really looking at your historical data, because your historical data gives you the ability to really understand what you're using, what those costs are, and really as you move forward, how do you price? How do you negotiate? What's your vision and strategy? It's going to be based on your historical data. Cost management, we're going to give you some examples going forward of some of the work that our clients do in cost management, but having that monthly discipline of getting to the line item details and seeing your spend and being able to make strategic decisions in real time, not always kind of looking back every year or two and kind of doing a performance improvement initiative, which is great, but we want to move hospitals into that real-time management of cost. Operating room focus, purchase services focus, and what we call the 4 Ps, process plan, project management, and performance. So we're going to hit on a couple of slides. Like I said, a couple of slides, we're going to go a little quicker. So every cost-saving strategy has to have a plan. You need a roadmap for success. You need a process. It's a repeatable, proven process, so that whether that process is how you collect data, how you analyze data, how you engage in your internal team, what your accountabilities are, project management system, but you need a repeatable, proven process. 3, project management system. How do you track cost savings initiatives? I mean, I think one of the biggest areas of opportunities is shortening the time to complete a cost savings initiative. And a lot of things happen, there's really legitimate reasons why, but we're always pushing that timeline to a shorter timeline, not to diminish results. We get the same results, but we're saying there's no reason for a cost savings initiative to take 3 months, 4 months, 6 months. Really, when we work with our clients, we're driving to complete projects within 30 days or less. And sometimes it doesn't always happen. Sometimes it happens in 2 weeks. But because we set that mark, more times than not, we're successful in achieving that mark. And performance, exceeding industry norms and measuring, constant measurement. Talked a little bit already about zero-based budgeting. We're going to talk a little bit about clinical utilization and value analysis and 5 questions that we ask. What does the product cost? Are there similar or identical products that cost less? And that could be whether it's in your GPO or outside your GPO. Really, you need to have a full view of what is offered, with costs and products. How will the product affect patient care? Are there community-related concerns? Are there any major environmental concerns? And where does the waste occur on a regular basis? That's a great question, because that's a mapping question that will uncover opportunities. What are known problem areas in terms of inefficiency? Another great area for improvement. Are there issues with personnel staffing? Are policies, protocols, policies, and procedures updated, regularly enforced? And are lean processes in place? And I think lean processes, as everyone knows, particularly, let's say in the OR, are very, very important for optimizing, even supplies, time. And of course, we're back to pricing, but I want to mention one more thing on pricing is, hospitals can't charge more, right? They're capped with federal reimbursement, state reimbursement, and managed care agreements. And so, again, we have to become, as an industry, really saying, wait a minute, we've got to take a hard look at pricing, because, most of those cases now we're managing to Medicare margins. And so there has to be a refocus on, wait a minute, am I getting the right price? And there's so many market changes that are occurring that there is a need for a hospital to continuously review and to use various sources and to be very creative and innovative. And I've seen some, amazing innovative work around pricing. And, again, I think this is very, very important, part of what we talk about, because you want to make sure you get the right price. And that may change several times over the course of an agreement, and everyone's got to be okay and comfortable with that, because hospitals just can't charge more. I spoke a little bit earlier about supply chain excellence, investing in and building a world-class capabilities in analytics, in sourcing, negotiating, contracting, but it's so critical to have a strong supply chain team. Cost awareness is a lot of literature, and in our work working with hospitals, that if physicians know the cost or see the cost on a regular basis in real time, they have a different view on it, and it's how the data is presented. Do they trust the data? Is it done in a consistent manner? It really needs to be weekly. It could even be daily as they have surgeries. But what kind of cost information are you providing to your surgeons? Because for example, in the OR, because I will tell you, my experience is when they see pricing, they see options, and they see it in a way that they trust it in a consistent way, they will make changes. And it was interesting. There was a study in JAMA. It was a recent study, and for those of you who are interested in it, I could send you the full study. Just presenting the cost data to the physicians in the intervention group decreased cost by 6.54%. There's nothing that was done. It was just a feedback system, and it was just presented. Well, what I think was even more fascinating, though, and insightful, is that the control group who didn't have cost data, their costs increased by 7.42%. So by doing nothing, your costs increase. And so I think we see that, just intuitively kind of in our work. And so there's a 14% gap of cost savings and cost management opportunity from just presenting the costs versus to not presenting and doing nothing else. These kind of programs can easily be established. It's a matter of just saying, okay, this makes sense, it's logical, let's roll up our sleeves and let's get a cost awareness program in the OR in real time and get some buy-in and feedback from our physicians.
Right, and this example here is the question that we're coming up with of, insource to outsource, or in this case, outsource to insource, and what that analysis looks like. And in this case, our client was able to reduce their monthly cost from $72,000 to $26,000.
Yeah, and so that was just a different way of saying, what, we're insourcing, we've been doing this for so many years. We've been outsourcing, we've been doing this so many years. We should evaluate whether we should bring this in. And in fact, yes, it was a change, and sometimes we all don't like change very much, but the change was enormously successful, and the organization was real happy with it. Spend analytics, we're going to have quite a bit of slides to show you the value and the importance of spend analytics, but it always begins with a baseline, a historical review of cost, utilization, outcomes, and then that ongoing monthly management. Develop key performance indicators to analyze and automate. It's so important by department, and it doesn't have to be 30, dashboards or 30 areas. It could simply be 3 or 5 specific areas you're looking at every month, but with consistency. And a specialized focus in the OR. We're going to give you some examples, but we're the OR has the highest potential for revenue, but also highest cost. And so the OR needs very consistent line item detail eye on cost and reimbursement and measuring the surgical line, profitability. And having an overview. This is one of our spine service line overviews where we kind of look at savings and spend by construct. And Rich is going to jump in. We're going to go through these quickly, but we want to give you some thoughts and ideas about how you can go back and you can have a different view if you're not doing this already, how you can analyze cost per case.
Right, and just want to point out it's very important to have data integrity, especially when you're presenting to physicians. And in this case, obviously the overview, but this is profitability by surgeon, by DRG. And then it's a mix of the specific, this one physician's reimbursement analysis based on the payer mix.
What's interesting is, in my experience, that sometimes physicians think that and it's not no fault of their own, it's just they think that, because they're bringing in a volume of cases, they're bringing in a volume of money and profit. And sometimes when you're giving them the data to say, wait a minute, I've got private, I've got Medicare, I've got some Medicaid, and I've got some charity care. So, when you're providing this and showing them the implant costs and implant cost to payments, they really, they often, what they say is, no one's ever presented this data like this to us, but this, I'm on board. I get this, but I've never kind of seen this, analysis of what goes on the back end of, the business side of healthcare.
Right. And just having that data, again, you can have, you're able to break it down from a vendor from a physician standpoint. What's the variance, the best practices, but it also leads to, when we look at having this data, is to really identify other issues. In this case, it was a charge capture issue. And now having that data and be able to go through it and do the analytics around it, they missed $349,000 in missed charges.
And what was interesting, I just want to go back real quickly, is that you have one physician, the reimbursement to implant cost is 38%, and then the other is 52%. The standard is about 35, 30, 35, and giving them that information, again, is so important. Always looking at implant costs to payment analysis and baseline to Medicare as a payer is important. And what Rich said was really, really important, because while we help hospitals with a perioperative assessment and helping them improve and charge capture and reviewing how they're performing and how they're accessing, how they're charging and billing, you can see a lot of this just from the data. I mean, really, we help hospitals get views on this kind of data so they can analyze and say, wait a minute, this doesn't make sense, because this just can't make up a lumbar case. There's things that are missing. And as I said earlier, part of having a cost-saving strategy, there has to be a specialized focus in the OR, and there's just many different aspects to that, and whether it's process improvements, it's clinical part, there's governance, there's charge capture, there's staff optimization, and of course there's the cost and also the patient satisfaction component. I wanted to give you a highlight. One of the areas that we look at is infusing 4 different data points, and those 4 different data points are cost, reimbursement, outcomes, and social determinants, because social determinants are very, very important. And that's what I talked about earlier, is constantly innovating, right? Costs are important, reimbursements are important, outcomes are critically important, of course, and now we've got to infuse the social determinants. And so when we're infusing those 4 different data points, you're really elevating, looking at, a non-labor strategy, or adding to that strategy. We're going to talk a little bit about our cost management through our patented technology. And all our work is grounded in line item detail, in granular detail. Aggregate information is fine to see a big picture view, but if you want to get to cost savings, if you want to get to cost management, you have to have the line item details, the granular, the data is so important. That's where all the savings, the opportunities are. And so when purchase services spend, everything is manual. That data is on the invoices. So unlike supplies, where you push out an order, services are performed and then invoiced. So the invoice becomes the record. And so it's a very arduous process for hospitals to get their arms around 50% of their non-labor spend is in services. So we've spent a lot of time and dedicated time to help hospitals get the line item details. So they're able to not only just save money, you can do that as a one-time event, which we're a big believer in, of course, but how do you manage costs, and how does the cost management become the big driver of performance? I could show you financials from just about any organization, and you see an increase. You can look at this as one example of publicly available data, and you could just see professional services growing and all these purchase services growing year after year. And while we have more of a focus on it as an industry, there is still an enormous opportunity in purchase services spend, and some of it's because we're just tackling it, looking at contracts and trying to renegotiate quickly and trying to have some savings, but what we're not doing is putting together a real focused cost management system in place. And so, like Rich mentioned earlier, what we see, something as simple as a CPI increase can eat away at those cost savings. But a lot of other times it's just not having visibility into line item spend and seeing errors, off-contract spend, just different patterns of utilization that aren't picked up in real time, and they're picked up 2 years later, and after those 2 years, you've just had an increase in that spend. So it's a little bit what I just mentioned. There's no automation into gating the visibility. It's manual. There's all kinds of complexity around service and spend. So we're going to spend a couple of moments on these. I'm going to go through again the slides, some of these quickly as we have, we're getting close to our time. Some of the realities, like I mentioned, the purchase services are complex, particularly when there's variability in the agreement. We've got to make informed decisions. Vendors are highly skilled negotiators. They change. The structure of agreements are making them more complex, difficult to kind of audit, difficult to kind of get your arms around it and manage it. And industry norms are just not enough. And the sooner hospitals can get out front, the better. We've got to really take a different approach to cost savings, which is this disciplined approach to cost management. So I've got some case examples for you. We had a hospital, several hospital system, tens of thousands of invoices, hundreds of thousands of line items. And we were able to capture, using our technology, a 2-cent line item fee. That's a $624,000 unnecessary cost because we had access to line item details. Again, this is a regulated medical waste invoice buried in thousands of pages of invoices. There's a monthly invoice fee increase. It was $3,389 each times 10, $33,000. And what was interesting is this hospital had a tool that showed aggregate data. So they saw aggregate monthly data, and in this month, it dipped. So it was a low spending month. Yet in the low spending month, it was a $33,000 error. This is why you can't rely on categorization as a management tool. It's great to have a view, but you can't rely on categorization as a way to operate and run purchase services spend. You need that monthly management of line item details. This is another view. We're using our Invoice ROI technology where we're able to, for storage, look across a number of different hospitals within the health systems and be able to see same services, different pricing, but be able to give this to our clients in real time. And then Rich is going to jump in and talk a little bit more about nitric oxide.
Right, and this is, again, what we're talking about with the net hourly rate and the unlimited plan, and really what an area that you can, with a renewal, you'd want to focus, and this is an example, if you look at, this is what a typical invoice would look like, right? This is the backup of the invoice, so this is going to let you know when the hours are being done, when it's turned on, when it's turned off. And what we've identified, and when you go back to your 12-month utilization after you, extract or put them into Excel, is that you can start to see the patterns, and when there's this an example right here highlighted in yellow that this was turned on. I'm sorry, it was left on. And this is a great example because once we were able to identify this and many other ones, we were able to go back and then on the renewal lowered the overall baseline cost for their unlimited plan, and it saved them $224,000.
And that's why sometimes when we hear, oh, well, don't worry about this, we have an unlimited plan, we often say, but wait a minute, that's based on your historical spend. You do need to look at it. Your unlimited plan is relevant, and the line item details of the usage is very, very important.
Right. And then this is an example of lithotripsy and pulling in the reimbursement. And that we were able to show the physician that the hospitals make $140 per case.
Right. Again, just pulling in, being able to look at costs, reimbursement, and then not only benchmarking, but being able to show the real profitability and giving the physicians the real profitability, like Rich said. And we're going to continue with Reference Lab. And so this is an interesting view. This is one of our hospitals who are using, kind of a line item analytics to understand their Reference Lab spend. They pull in from various companies, and we're able to show initially whether something is the right price, wrong price, on contract, off contract. If it's off contract, then they know they've got to renegotiate, but they're also really, really, this becomes the platform, and they really love this way of viewing it because they can change utilization. They can bring tests in-house, but they're seeing their data in real time, and it comes from their invoices. It's the data it's their utilization. So it's taking, what comes from their invoices and giving them the optics on utilization and where they can focus on, reducing costs, looking at leakage. Again, another view, 15 off-contract tests. Those tests need to go ahead and be put on an agreement. You could see the line item details below, where the reference, where the lab director now can make some strategic decisions about their spend. Another view is regulated medical waste. Looking at minimum fee charges could really unearth some significant savings. I would say never think that is not a big opportunity for savings, because it is. And pulling in not just your contract, the invoices, but actually the real weight. And in this case, this hospital had a contracted weight of poundage much higher than their last 5 months utilization. In fact, they were overspending by $9,700 a month. So just minimum fees and looking at really what's going on, the real utilization brought in $200,000 in savings. But that's only possible when you focus on the line item details. This is a quick view of categorization, as I talked about earlier. But really getting into the line item details. This happens to be linen, and understanding what's on contract, off contract, what things have to be confirmed. There's some pricing variances, but being able to go into the line item details, the invoice line item details, to see specifically what are the areas concerns, and be able to do it in a dashboard, not have to go through thousands and thousands of invoices, but kind of have that viewpoint to manage strategically. Again, another view for telecommunications, the line item analytics dashboard, being able to understand what the utilization is across the system, whether it's circuits, whether it's PRIs, and where that spend is coming from. Again, giving you the optics to manage on a monthly basis. Rich is going to jump in real quickly to talk about some rev cycle opportunities. We're probably going to skip some slides now, but again, please ask for the deck, and you can always call us and we can talk through that, but we want to leave a couple minutes for questions.
Right. And this is a quick example, like Lisa said, where when you look at, you benchmark, you can see that rates were competitive, but when we went to the statements and the invoices, we realized that if it was because of the way that they were getting the reports, they were zeroing out the balance, so therefore it was defaulting to the highest rate. So just getting that adjusted, we were able to get a $57,000 credit, and then annual savings almost $230,000 a year.
Okay, financial tools.
Right. So these are now, when we look at the from a financial services vendor, right? So this is, again, patient eligibility verification, and really what this represents is understanding the actual utilization, right? So you can benchmark and you can come in, but getting the invoices and understanding where the utilization is, then you can make strategic decisions. And in this case, they're based on the transactional history. The client was approaching their limit and therefore was going to get a penalty fee. Now, when we first went to the rep said, no, we can't do it. You can only do it once a year and then on their anniversary date, and it wouldn't have saved much money, and then they would have obviously had a penalty of about $68,000. But when we were able to dive into the usage and utilization, we realized that one of the hospitals in the health system was on a separate contract, yet they were still paying that other hospitals through this main agreement. Therefore, it was a mistake. So we were able to get them to adjust this. The $68,000 was wiped away, and then they were able to save about $83,000, $82,000 annually on the agreement.
So we're skipping a couple of slides because we want to get to some additional information, about process and about strategy. So we'll do this one.
Right. So this is a really good example of really mapping for, this is a health information solution. We were brought in. They couldn't get their hands around the volume of invoices and reconciliations each month. So we were looking at the invoices, what could be paid, what credits were from overbilling, and then cost reduction opportunities. So what came out was just one patient statement, which doesn't sound very expensive, but when we looked at, there was 3 separate agreements, and the 3 separate agreements had about 38,604 minimum statements per month, so the combined 3 of them. And then when we asked, we found out exactly how much they were. It was about $104,000 annually. So that just adjusting it down to competitive pricing and reducing that monthly minimum saved them, $219,000 a year.
Right. So we have some, our questions are kind of, we got a lot of questions. So I'm going to kind of skip through a little bit of this, if you don't mind, and again, show you just some optics into how high-performing hospitals are performing monthly cost management for their departments. Again, this is reference lab, but you're able to see contract status, and you're able to see those line item details. Again, this is another view on a monthly invoice and whether it's off contract, the right pricing, but I think really very important to get those optics into real utilization of lab. Do quite a bit of work in this area. I'm going to skip some of these slides and get to your roadmap for success, right? So there's 8 areas. You need a plan to implement, commitment from leadership, accountability, structure to measure performance, resources to support and accelerate success. Data analysis is so key, and the identification of opportunities. Physician engagement, clinical engagement, they are the major driver of utilization and cost. And again, I can't overly state the internal skill building for sustainability, and an effective cost management system for cost savings in real time. That is a roadmap for success. Always in collaboration with a cross-functional team. Finance, supply chain, performance improvement, department leaders, nursing, and physician champions make, you want a small, agile team, but a really engaged team. Something to think about, if you were having this discussion 2 years from today, you were looking back over 2 years, what would have had to have happened in your hospital for you to feel happy and successful with your cost savings progress? What are the dangers you need to eliminate? What opportunities need to be captured? And what strengths need to be maximized? Important question, and you can actually ask that question in a lot of different contexts. This is a little bit about why. We uncover opportunities, supplies, pharmacy services, cost to charge, inventory, physician agreements, and joint venture agreements. We help hospitals develop a strategy. We lead cost saving sessions, and of course we do quite a bit of work around cost savings and helping our hospitals accelerate their cost savings initiatives. So I'm going to jump to questions. I got a couple of slides. Rich, did you want to say something? Nope, we're good. I am going to just give me one moment while you just look at this cost saving strategy session into a roadmap. I just want to be able to answer some questions, so bear with me. Let's see. Let's see. Okay, so we're going to answer a question from Jeffrey. Jeffrey asked, are these examples of reports conveying opportunity for savings from your proprietary analytics tools? Yes, that is Invoice ROI. It's our patented technology, but these are all proprietary. But we help hospitals build them internally as well, because I'm a big believer in building competency. So we have some hospitals where we help them set these reports up, set the systems up so they can sustain. So thank you, Jeff, for that question. Let's see, what other, so your mention of generally a short period of time to complete an engagement, is that per initiative? What if your client wishes a comprehensive engagement following multiple cost-saving targets across many of those initiatives you provide as examples? So it's a great question. When we're performing a number of different initiatives, of course, that period of time is longer, but we are literally in parallel running 5, 6, 7, 8 of them within that 30-day period of time. So it's a great question. And, you know, we have large-scale engagements where we're working, 6 months, 9 months to really capture, identify, and achieve those cost savings. But as we look at those individual initiatives, we're never going to have one initiative go out, 60 days, 90 days, 120 days. We have a project management system, and we operate by milestone. There's 7 milestones we use to complete one initiative. And our DMARC and time frame is always a 30-day period, and we can tell you where we are in each, step of the way. That's a great question, so thank you. Let's see. Just got to read some of these. As someone in healthcare costing for the past 15 years, I appreciate the presentation. I draw similar fixed components into doctor's pay, housekeeping costs, and equipment rentals, but do you think we can renegotiate for a short time with this COVID effectiveness? It will obviously drive other stakeholders out of business. Okay, great question. And so, yes, we do have to negotiate for a short period of time. And that's why I brought up the progressive example. I'm not saying that you have to, look at years, but during this period of COVID, between 3 months, 6 months, there has to be a time, where, we're all going through pain, and I think it is unfair to have an agreement that is a fixed fee agreement, and no services are being performed, and yet the hospital has to pay. There is unquestionably, if it's a vendor partner, they will partner, and they should partner, particularly if they have no cost going out. So what would be the reason back for them to say we can't do that when there's been no cost associated with servicing that contract? So thank you. Great question. How do you determine if a cost innovation is worth implementing, if it's break-even time frame, ROI, or percentage, or other? Thank you. It's a really great question, and I think that what I wanted to bring to everyone's attention is we should be looking at those different cost in innovations, right? And I think the implementation is, I think it's always is savings. There's value. There's conversion. There's a cost to convert, right? There's a cost. You can't always look at just the numbers. It's how will it impact the hospital? But I'm a big believer in the savings point as that fundamental reason for change. If all things are equal and there's not a big transformation necessary, but I think it's that cost savings and that consistent cost savings, and really it's the guaranteed cost savings. You just can't hope that it'll achieve. If you're going to make a cost innovation, then somebody's got to really be committed to making sure those cost savings are in fact achieved. Okay, so I think we're going to, I have a couple more slides, and then we'll end. And I really appreciate everyone's engagement today. I also promised a 14-day implementation plan. It's to assemble the data, but this is before the 14 days. conduct a strategy session for cost savings, create a 2-year plan, chunk projects into 10 projects for focus, and then cycle projects into 10 weeks. Of course, you know, we talk about 30 days, but you know, we're always a driver, right? We're, you know, advise a lot of times hospitals bring us on board to drive cost savings, but you know, we are flexible to understand that some of that needs to be, you know, internally you may have other competing priorities, so we say chunk them. And thank you for attending the webinar today. I have about, I think my time's a little bit run out, but if you have any questions or want to schedule a call with myself or Rich, please reach out. If you need any effective way to jumpstart your cost savings goals or the cost savings strategy, please, we have a 4-hour Zoom session with your team. You can reach out. Stay to the end. I appreciate it. If anyone as a hospital or health system with like a benchmarking analysis, we'll provide one for you at no charge. Reach out to me. I appreciate everyone's time today. It was great. Thank you very much.
Yes, that is all the time we have for today, and I just want, on behalf of Becker's, I want to thank Lisa and Richard for that excellent presentation, and Vi Consulting for sponsoring today's webinar. Enjoy the rest of your day, everyone, and we look forward to having you join us for future webinars.